So here we are, exam two. So I have Elizabeth with me, and we're just going to rock and roll with it. So, exam two, weeks 4, 5, and 6. A lot of chapters, a lot of information, and it is scary. So, I'm going to try to relieve some of your stress here. Oh, Diana joined me too. That doesn't surprise me. Good evening. Good afternoon, Diana. Welcome to see you. Okay. So, exam two, you come in, just be prepared. If any problems, always before an exam, you let the professor know. We can do things before things happen, afterwards, we cannot. So, let's go into some cognitive delays, impairments, things that we might see in children. So, eyes. Eyes are important. One of the conditions children can have is something called a lazy eye. It is known as amblyopia. So if something doesn't work right and the muscle is weak, what do? You exercise it. So cover that bad the good eye and make that bad eye muscle work. And that's how you fix it most of the time. We also have nystagmus, which is a cross-eyed, and then we have strabismus, and they sort of shake back and forth. And those are the three different eye type things. Strabismus, I think, is when you look at them and they just don't get there, and their eyes tend to twitch. Okay, early cognitive impairment. This is a child who's not meeting those normal milestones, those developmental milestones. This is why we do these testings, because sometimes we can say by the look what they look like, but sometimes they look normal. And now we got to figure it out. So we sometimes have those dysmorphic. Again, this is a child that's going to be out in an environment, it's not going to respond to you. Absolutely, there'll be gross motor delays. They might not be walking at 1-year-old. It may be 2-year-old when they start walking. Fine motor, are they taking their hand and grasping something? Pincer grasp, are they able to do it? Most of them are very delayed. Also, language. Usually by age 1, you are speaking at least mommy, daddy, one word, some things, and they're not yet. And then I think the one thing that we get frustrated as healthcare professionals is behavior difficulties. If you can't express what's bothering you because you don't really understand yourself, don't comprehend, how are you going to act? You're going to be having problems. You're going to try to overreact. Let's get some attention because you need to listen to me. And that's that behavioral difficulty. So I don't respond. I'm going to have major delays, poor language, and I'm going to be a little bit harder to take care of because I need myself seen. So Down syndrome, one of the biggest commonest syndromes that we think of when we think of cognitive delay. So Down syndrome, they've got a lot of things going on. We've just learned this week that leukemia, they're at high risk for leukemia. They're high risk for congenital heart disease, and we're also at high risk for hypothyroidism. So these poor Downs children, not only are they cognitive delayed, they've got, these the fingers are short and stubby. Even their mouth is a hard, very high arch, and that tongue that sticks out there. The other thing that these Downs children have an issue with is these underdeveloped nasal bones. What happens with mucus? It gets stuck inside the nasal cavity and they can't blow it out. So what happens? It drips. And then it creates a lot of upper respiratory due to all of that mucus. Also, if we have these children in a hospital, these children, they're super high anxiety. They want somebody there that they know. So we will totally encourage a parent to room in with these children. And what happens if we can't have those parents there? Let's have consistent staff members taking care of them so they know who's coming next. And that can help a little bit. And I think the one thing that dictates, schedule for any younger child is when is my bath time? Because it breaks the day up, right? Some of parents like it in the morning, some like it in the evening before bed. Let's keep them on that same routine. That does help. So autism, it's like that cognitive delayed child, right? These kids, we do not diagnose till about 2 years old. Yes, we can see symptoms coming up to it, but they do not put that label, that diagnosis on till about two. These children really have a hard time focusing. They don't like looking in your eyes. I am in a big rainstorm right now, so if something happens, I will be right back, okay? It happened when I came on right now. So you're going to see they don't like to look in your eyes. They are not going to respond when you call their name. And these children like to do these repetitive behaviors. I saw this one little child when I was doing clinicals. He was actually autistic Downs, if you can imagine. And this child would sit in the corner by himself. He would have like a chair or a stool next to him. He'd sit on the floor. He would take a truck, put it on top of the chair, take a block, put it on top of the truck, take something else and put it on top of the block. And then he would take the top thing down, take the block down, take the truck down. And he would back and forth do this over and over and over again. That gives them comfort. Okay, that's why they do that. Again, they're going to have verbal, fine motor, gross motor delays, absolutely. Behavior difficulties, again, absolutely. It's cognitive delays. This child can't express themselves. They play alone. And the other thing is when you put certain textures in their mouths, they don't like it. Whether it is slimy, whether it's chunky, it doesn't matter. They have this aversion. The other thing is they don't like big, loud noises, okay? Biggest nursing consideration with any cognitive delayed child is safety. They don't know not to put things in their mouth and swallow it and choke. They don't understand. It's not like the little toys under the age of 3. This is older. You've got to be very careful. So verbally, children, how do they speak? Well, they start making some sounds early on. They cry, right? And then they start by 3 to 4 months, they're cooing. And by 10 months, they can understand no. And they're starting to say things, mama, dada. Around 12 months, 1 year, absolutely, they're going to do it. And by 1 year, oh, they know about 3 to 5 words. Mommy, daddy, hopefully Nana for me, or maybe milk, maybe juice, whatever their thing is. Now, when you're speaking to a child and they're not responding back, or they're not having all of, speaking the way that they should, it could be a problem with hearing. If you can't hear other people speak and get that repetition of words, they're not going to be able to express it. So again, if you have a child who has problems with speech, go get a hearing evaluation. That's first, number one. Now, children in the hospital, you think that they're never there for these long-term sort of things. And oh, yes, they are, just like the elderly. And many of the things that you study for the elder patient, the older one, still you're going to put into the same thing with children. So you have a child long-term in bed. What do we need to do to care for them? Well, number one is nutrition, nutrition, nutrition. If you don't feed them proper nutrition, how are they going to keep themselves from not breaking down and getting decubituses? Or if they have little abrasions, how are they going to heal? You don't have protein, you're not going to heal, right? Because protein equals healing. We're going to be using draw sheets. We don't want to just rush them up the linens. It will sometimes rip the skin off a shear injury, just like adults, but children can too. We're going to rub them with moisturizer. We're going to keep them dry, whether with a pad like a Chucks or with a diaper, making sure we keep them dry. And then whatever sort of turning, positioning, we can use blankets, we can use pillows, we can use toys. I've used everything to position my children over really, really nicely. So going into the hospital is a difficult thing. And it also really depends on what is the age of this child that's coming in. I think toddlers are the most difficult because they really need mommy there. Also, they're so busy, you've got to be careful safety wise again with these children also. So, again, when you're speaking to these children, got to do something, let me say, draw labs or something. Make sure you prepare them on their developmental level, okay? Also, I think, and it's something that I did my research on, is how if parents held a child, we saw less stress, pain, and anxiety because that was in mommy's arms. So before, during, and after, they had that comfort. So again, sitting on mom's lap, absolutely appropriate. Trying to maintain that child's routine. I think the bath routine is how we can get that all together. Of course, we'd love to have parents to stay with their children, but remember, children sometimes have to understand there's other kids in the house, they've got to work. I mean, they have to go sometimes. It is a great source of anxiety. And remember that separation anxiety. What's the kid going to do? He's going to scream like the holy dickens when mommy and daddy leaves, right? They want mommy and daddy there. And then they realize, oh my goodness, they're not coming. Second stage is the regression. Start to suck their thumb. You might even see them, pee their pants where they haven't done that in so long, right? So that's second stage. And then mommy and daddy finally come back and they don't pay attention. Third stage, because they realize if they pay attention, they're leaving again and I'm going to hurt again. So they sort of protect themselves with it. Now, in the hospital, we have such great things and tools to use today in the children's hospitals. I was very blessed to work at the hospital I worked with, and they were very, very progressive. We had something called Child Life there. Child life was children were being played with by a person who has a minimum of a bachelor degree on childhood development. So they knew what was appropriate for these children to play with and would help them play. Okay. So play can tell us things that are going on with a child. So expressive activities are the one that there's something going on, they're frustrated, it's a long hospitalization. We can let them get that frustration out, can't we? Throwing a ball, riding a bike, doing whatever makes them feel better. Dramatic play is when we have an incident where a child was upset by some sort of procedure, whether it was an x-ray, whether it was a lab draw. This child, through play, can show us what happened, and we can correct that, whatever it was. And then creative expression just basically lets the child shows how they feel. So different sorts of play. I love play. That's why I went to work every day, to play with children. Can you imagine? I was paid for that. So children in the hospital can be in pain. And the reason for this slide is talking about, number one, if you have a child who's had surgery, you have to do all of those things to prevent these complications. Remember, children are not going to ask for pain medicine like adults do. So make sure that they're well medicated before we do things. They're not going to cough, deep breathe, get out of bed, and ambulate the way we want them to if they're in pain. The other thing we can do is distraction. So let's get up and ambulate, and I start dancing. Come on, let's go do the tango down the hall. Now, I've done that before, and kids start wiggling their booties and everything and think it's great. It's a great distraction. If they're in bed, it could be giving them an iPad, turning on the TV, music, cards, crayons. I mean, there's so much to distract children, and they love to play, don't they? One of the things about children and procedures, there's many procedures. I'll probably say it a couple times during this review. If you have to do something that's going to hurt, you have to be honest with children. They want to know. They don't want to all of a sudden scream and yell because you pinched them for whatever you were doing to them. Let them know it's going to hurt, but you're going to do everything possible to make it as little pain as possible. Now, giving medications to children can be pretty hard. Some children take it with no problem, and some children, oh my goodness, it was like you were trying to do something that was going to really hurt them. So, infants, put them under their arm, and you could take and put it in a syringe, but remember, just a little bit in the side of the mouth. If you squirt it in the back of their throat, they're just going to gag and choke and vomit. You don't want to do that, okay? So very slowly. One of the tricks I've learned is if you put a medicine in the mouth and you blow quickly, it scares them, and they swallow their medicine. And I teach the parents how to do that. IVs in children are a little different than adults. If you can imagine, 30 mLs of fluid in that arm is different than an adult. Adult would be, you need 300 mLs to almost do the same sort of quote damage. So what do you do when you have a child with an IV? You assess the site, right? For swelling, redness, pain, I call it erythema and edema, blood. And what do you do if you suspect it at all? Number one, stop the infusion. Look at it and then evaluate it. If it's, yes, infiltrated, it needs to come out, elevate it. Tell the doctor, get the IV out, and maybe a warm pack on it would work. And a hospital improved warm pack. Drawing blood from infants. We can do almost any type of blood draw except blood cultures and bleeding coagulopathies with a little heel stick. Now, I love the picture of this heel, where they putting that little lancet. Number one, it's an appropriate one for an infant. And where they're putting it is on the sides of the bottom of the heel, not in the back. If you put it in the back, your calcaneus is there, a bone, and that little lancet could hit the bone, and now you have osteomyelitis, and you don't want that, okay? How do you get a great sample? Well, hospitals have great warmers, and don't do a washcloth, don't do one of your things, no, because you can burn infants really quickly. They're very, very sensitive. So use a hospital improved warmer. You put it on. If you hold the leg down below the heart, squeeze the leg and the foot slowly, easily, you can get blood and not harm that back of that heel, cause bruising or anything like that. Another thing with infants is how to get a urine specimen. Now, in some of my classes, I had a quiz question that said, put a cotton ball in for routine urine specimens. That means a simple, specific gravity, glucose. You just need a drop. So cotton ball, then you put it in a syringe and you drip a little bit of urine. But what if you need a urine specimen for a child with a fever? So you need an accurate urine to determine if there's bacteria in there and if it's treated. The only way is a catheterization. It is not a bag. It's easier to do it one time, get the appropriate antibiotic, because these children do not have any immune backup at all. You want to treat that infection the first time. Oxygen. Children at birth, sometimes they're born with transient tachypnea of the newborn, which just means they got a little fluid in their lungs and they just need a little oxygen, and they come around really quickly. The easiest, most tolerated way is that little oxy hood up there. If you look at that child, it's up looking around, they can take their hands, they can suck on it, suck on their little pacifier and be happy. Nasal cannulas, we have to tape on their face. So they're taking their fingers and ripping it off. And BiPAP or intubated, Again, you feel like you're gagging and choking on them. So easiest, best tolerated and accurate oxyhood. Now, again, we're talking about children, stress, being in a hospital, that separation anxiety sort of thing there, right? So again, separation anxiety is that absolute biggest stressor for any child. We know parents, if at all possible, should be able to stay with a room with them. And I've always made sure they had a pillow and a blanket. And please stay with my kid because I know they're happier. We know children that are male, 5 months to 6 years, cognitively delayed, are the ones that are going to be the ones that really need parents. So during the hospital, they're upset. What does a child do when they're upset and when they're stressed? They regress. They don't know what's going on. So they just, start sucking their thumb again, right? And that's absolutely normal. We expect those sort of things. We have young kids who are potty trained and now they don't want to go into the bathroom. We have children that used to sleep all night long. Now they don't want to. There are excuses for being awake and having people around them. So again, the biggest stressor is no parents. School-age children who are hospitalized, they are older. They tolerate parents not there as much, but we've got to keep them busy, especially for extended type visits. Remember, if we're doing care on these children and we're trying to keep them busy, distracting them with different things, maybe they have to do schoolwork at home or maybe they have something they have to do. Remember, like Erickson says, whenever you introduce them something that to distract them to do, make it something challenging, but make sure it's not something that they cannot complete because that will lead to even more frustration. Ear infections, otitis media. Number one priority care, pain. Now you're going to say, why not antibiotics? Well, a child comes in with chronic ear, this otitis media, this pain in this ear. The antibiotic's not going to work for a day or two. You've got to deal with the pain first, okay? Why do children get ear infections a lot? Well, they've got all this mucus in their nose. They don't know how to blow it out well, right? So where does it go? Areas of least resistance. And those narrower, shorter, open eustachian tubes right up into their middle ear. What do we use for pain? Just acetaminophen, Tylenol. That's all it needs, really. But give it to them and give them a proper dose. This sort of ear, that oozy juicy, it's already burst. It's been so much infection in there. That child's going to get drops in the ears and oral antibiotics to be given. We know that if it's a chronic otitis and they're chronically getting ear infections, they might have to have ear tubes put in. So one of the things that we say about otitis media in children, it is caused by smoking, secondhand smoke. So again, nobody should be smoking in the house with these children. Also, keeping their immunizations up to date. Immunizations do protect them for even ear infections, like the Hib one is a big one at 2, 4, 6 months. So a child with an upper respiratory infection, let's talk about bronchitis. Another name is tracheobronchitis. It's the trachea and the bronchus get inflamed, they get a little narrowed, and this is probably the most annoying of all type of diagnoses. Non-productive, dry, hacking cough, worse at night. How do we treat it? Well, it's a virus, so symptomatic treatment will always be part of it. Rest, fluids, antipyretics. You may or may not have a fever with this, but maybe from all that coughing you heard, you might need acetaminophen or ibuprofen. So croup. Croup is very distinctive. This is a child who is barking. Sounds like a seal, really. You could be in a grocery store and a kid on the other side of, 4 aisles away would bark. Oh my goodness, that is a croup. You would absolutely know it. Um, Remember, this again is a laryngotracheal bronchitis. So it's the larynx, the trachea, the bronchus, it's all of those areas. It's another name for croup. And this is a child who needs to get treatment. It has a lot of problems with breathing air in. So in respiratory, you have upper airway and you have lower airway issues. The upper airway issue means air can't get in. It's swollen, air don't go. So it's inspiratory stridor. It's trying to get that air in, okay? As we get further to lower asthma, air can get in. There's nothing up here to bug me, but it gets trapped. So it's expiratory. So you got to know those two things. So croup, how do we treat it? Well, we know that this child, we have to sit them up. Number one, sit them up, calm them down. Will always be anything in respiratory. Maintain that airway, give hydration. If we need, put one of those mists on the child. Now, if this child was admitted and needed to have a mist and don't want to get under those tents that they like to do, how about sitting in mommy's arms or daddy's arms and have that mist just blowing in their arms and they fall asleep in mommy's daddy's arms and they're getting that moist, humidified air, which is what we want. Also, it is a swelling. It's a problem with swelling. How do you relieve it? Well, steroids, anti-inflammatory, and maybe a epinephrine air, aerosol, racemic epinephrine aerosol it goes right into that area where it's all swollen and air can't go in. So again, croup, inspiratory is all about the upper airway. Now, what if you had croup and the kid's barking and you didn't get to the hospital, you didn't get to the doctor? This is a child who can turn into epiglottitis. Now, epiglottitis is the epiglottis is a leaf-like structure that covers your trachea when you swallow. If you don't have room to breathe around these epiglottis, around this trachea, you can't breathe. So what would this child look like? This kid is going to be restless. This kid is going to be inspiratory. There's nothing going in. The kid can't swallow, can't talk, is going to be drooling, would be the speech that goes on them. And this child in a severe respiratory distress. So, as a nurse, what do you need to know and how do you care for them? Well, number one, you protect the airway. Get an intubation tray or a tracheostomy or both. Get them at the bedside because you may have to get that child with an alternative airway. Again, one of the things that we can do to help prevent this is that immunization, that Hib immunization. Remember, croup turns into epiglottitis. Now, cystic fibrosis, many of the times we know it when the baby's born, many times we don't. So we know if both parents have a trait, a child is 25% of having the disease. Just like sickle cell, isn't it? Same thing. These children, if we did not know at birth that they had cystic fibrosis, how would we diagnose it? Well, cystic fibrosis would have a meconium ileus at birth, which means no stool for 24 to 36 hours after birth. Cystic fibrosis, thyroidism, and then next week we're going to go into, 2 weeks from now, a GI condition. At birth, no stool. So we will be doing a sweat test, and that's how you diagnose it. I did put a picture of what it looks like. It doesn't hurt. They just put probes on the skin and they measure the chloride and the sodium in off the skin. These children, if you licked them, you would taste extreme salt on them. Cystic fibrosis is a three-part problem. It has to do with lungs, and it has to do with digestion and the electrolytes because they come out on the skin, okay? So, respiratory problem. Um, Respiratory problem requires very good respiratory care, chest CPT, aerosols. Here's a picture of that vest they put on, and it shakes them and it gives them aggressive CPT. Remember, these children, their lungs are wheezing, their rhonchi, their dyspnea, they really are filled up, and they really have to have an aerosol, one of those albuterol, Ventolin, open up the lungs, do that chest CPT, they can expectorate their secretions, and then we can give them their meals. But before their meals, we have to be giving them a enzyme to help them. What happens with these children is the pancreas doesn't produce enough of an enzyme that digests fat. So when fat goes in, even with these pancreatase capsules, it's very, very hard to digest fat. So you're going to have these bulky, oily, really foul-smelling stools. We call that steatorrhea. Because you don't digest or can't take fat, you can't use it, you're going to lose all those fat vitamins too, A, D, E, K. And because fat is so high in calories and you're not getting fat nutritionally, you're going to have weight loss. So children who have cystic fibrosis, they need extra salt because they're losing it like crazy, right? Because they can't eat fat or decrease fat because they don't use it. It causes abdominal bloating and gas and more stools. We need to have them on a high protein, high calorie diet, or else they're going to be losing weight. We're going to have these children on for these multiple respiratory infections on antibiotics. Azithromycin is one of the first line ones that we do give on these children. Remember, with these children, as we're doing these CPT treatments, make sure we do it before they eat. If we try to do CPT and all that after they eat, what's going to happen? They're just going to vomit, and we don't want that. Another thing we don't think of, because of the chronic and respiratory infections that they get, one after another, make sure that they clean their equipment every day. Every day it should be cleaned. So these enzymes that we have to give these children, before meals and snacks, they must take an enzyme immediately before, not 2 hours before, not an hour after. We need to take immediately before. They come in little capsules, like the little picture, and you see the little beads. We can't crush them. We have to keep them the way that they are, okay? It's just like an enteric coated thing. You don't crush them. Now, you could open it up and put it on a little food so they can eat it. That's okay. Also, if you got the powder medicine, we can give it a little bit of food and give it to them. But again, after powder, rinse the mouth. And then one of the things I think we always forget is, as the child grows, to increase the dose. I see this quite a bit with children. They grow maybe 10 pounds in 1 year and nobody has increased the dose. And I've seen even like seizures break through because of medication wasn't enough. Now, one of the things with cystic fibrosis is pregnancy, and it is mentioned in your book, and it's mostly mentioned about males and pregnancy. So women can get pregnant, not a problem. They're very high risk, of course, but men can't get the woman pregnant. There's something about there's mucus in the vas deferens, so that the sperm can't get to the woman, so they can't. But 2 hours, 1 year post bilateral lung transplant, they can get a woman pregnant. There's a higher chance of that. So many men do that for their wives. Tonsillectomy, TNA, with adenoids. Usually they do TNA, adenoids, and their ears all at the same time, right? But for tonsillectomies, nursing care, these children come out from the OR and they're very asleep. And we have just cut those big balls of tonsils off and cauterized them. So the chance of bleeding is great. So keep them side lying. And if they bleed, it will just pour out the side. We don't want them to, aspirate it when they're really still drowsy from anesthesia. After, we wake them up and they're sitting up and they're awake and ready to go home, we're going to be watching them for certain things. Number one, if a post-tonsillectomy child starts to swallow a lot, probably there's bleeding going on. And these children can bleed quite a bit. I've actually seen a child go into hemovolemic shock, throwing up clots the size of my fist. I mean, into this bucket. I had to resuscitate her with a lot of fluid that day. So it taught me a lesson about tonsils, that we really need to be careful. And that was 7 days post-surgery. Another thing we don't think about, tonsils are usually done as a school age child, right? What happens during school age years? They're losing all their teeth. So you can have a loose tooth in there and it's just normal because all those teeth are coming out by the time they become an adolescent, right? So be aware, loose teeth can be an aspiration risk. So post-operatively, no seasoned foods, no lemons, stuff that will burn the throat. Decrease the activities. They are to drink fluids, but again, remember, nothing red. We don't want anything red, whether it's juice, whether it's Jello, any of that. Another thing is these children, if they are still bleeding a lot, or still with big pain, that's when they should call the doctor when it's 5-7 days out. Okay. Oh, the one thing that I forgot to mention is older children, because of where the eustachian tubes are, a lot of them can get blocked and it causes ear pain. Like when you go up in an airplane and your ears sort of get plugged and they hurt, what do they tell you to do? Is to chew gum, right? Or try to yawn. Well, we don't want them to do anything to aggravate the back of their throat. So actually just chewing gum on older children can help. And the other thing is an ice collar. And older children will accept it. Younger kids will not. They don't want anything. Get it away and they'll just throw it off. So asthma. This is the one that's lower respiratory. This is where the air, we get it in nice, it goes down and it gets stuck and it can't get out. This is coughing, diffuse expiratory wheezing. This has nothing to do with a fever. Something tickled their airway and caused a bronchospasm. They call it hyper responsiveness. It could be due to cats and dogs and grass and mold and many different things. The thing with children is to figure out what is causing them to go into asthma attacks and to try to keep them away from it, right? So if they want to do sports and they're allergic to grass, you would choose a sport that wasn't in the grass. Or you would get them hypersensitized through injections, to desensitize them, but that takes time. So maybe you need to have them play tennis or inside in a basketball court, or maybe swimming, something else, because we want kids to be normal. So asthma, symptoms: frequent cough, losing breath easily, expiratory wheezing with prolonged trying to get that air out because it is so stuck. And Many of you in your discussion questions did talk about that peak flow meter. If we have a child with asthma, they should be checking their peak flow daily. And what it shows you is when you start seeing decrease amount of air moving, we can increase the aerosols and get the air open, right? Because it's telling you something's happening here. Let's prevent it from going from an asthma attack. A silent chest or an absence of wheezing is a high priority. My husband was in the hospital with status asthmaticus for 12 days. And you know what his breath sounded like? On expiration, I heard that little noise. That's all that was heard. He was in trouble, but we got him through it. So treatment, if you're having a problem, you can't breathe, you're feeling that swelling going on, it's albuterol, your rescue drug. If you give a rescue drug to a child with asthma, what would you expect to see as a positive outcome? Decreased wheezing, as simple as that, right? Now, if you have a child who comes in who's telling you, let's say you're in an emergency room and a child comes in and they're telling you that, you're getting more and more, short of breath and you've been taking your MDI, I'm going to ask, show me how you gave that child. Let me see how they do it because chewing gum and walking for people is hard. Pushing it at the same time could be hard. So let them show you many times. The problem is they need a spacer. So I will give them spacers and show them what to do. A child, first thing, what do? They're having an asthma attack. Sit them up, get them up, calm them down, whatever can calm them down, right? We know that the normal treatment for asthma is the preventative, which is using that albuterol for rescue, using those prevention morning and night. The one that we use for children is called Pulmicort. In adults, it's Symbicort, Advair, Brio. There's a couple of them. And Pulmicort, same thing. Little bit of steroid, and it prevents those bronchospasms. And just like adults, we give Singular. We started that about age 2. And of course, that peak flow meter is something that we do like to watch because we can say, we're getting lower in our air movement. Something's happening. Let's take care of it now. And exercise. We need these kids up, moving, breathing, and swimming is amazing. What do? They take a deep breath, go underwater. It causes positive PEEP, opens the lungs, and life is good. RSV, another common respiratory condition. For me and you, it's a common cold. For infants up to age 1, more of a problem. And why? Well, infants are, when they're born, the first thing they're taught is to suck, swallow, and breathe, right? Now, put on that a virus with mucus in the airway, a little fever, which don't make you feel good, and these infants are obligatory nose breathers. So now I can't breathe, I can't suck, I can't swallow. Now I'm going to go into respiratory distress. I'm going to go into nasal flaring, grunting, retractions, because I can't tolerate sucking, swallowing, and breathing. Now, children who have another coexisting treatment, like a congenital heart disease, cystic fibrosis, put on that a respiratory virus, a respiratory condition, they can't fight it. So there is an immunization, but it's once a month, only the first year of life, usually winter to spring, once a month. And what that does, it helps prevent it, okay? And again, this child might need a nice cool tent on them, maybe for some of the older children. Again, no problem with parents holding it. I think it'd be good. Pneumonia, it's a lower respiratory problem. It could be due to a virus, bacterial, or just be aspiration, right? Children, especially infants, sometimes we tend to overfeed them, don't burp them well enough. They have a little reflux, a little bit of milk goes into their lungs, and now they have an aspiration pneumonia. So we need to make sure we don't overfeed, that we do frequent burping, and that we have them sitting up for a minimum of 30 minutes after they eat. And that will prevent aspiration pneumonia from feeding. Also, smoking is always going to be there. Nobody should be smoking around children. And no powders. I loved baby powder, Johnson's baby powder. I think it smells great. But all of that in the air can really harm these children. So I've had to give up the Johnson's baby powder. Now, viral pneumonia. How do you treat it? It's a virus. How do you treat a virus? Supportive, symptomatic, fluids, rest, antipyretics. That's as simple as a virus is. And a bacteria, you just add on the antibiotic. And augmentin is the drug that the first one that they will choose for it. So viral is a pneumonia, but it's symptomatic like a cold. Same thing, fluids, rest, antipyretics. Now, mononucleosis is a very simple little disease and it doesn't do anything, right? Kissing disease. Well, mono presents with a sore throat and flu-like symptoms. Children come in, they do that strep throat test, it's negative. They do a culture, it's negative. They send the child home on supportive care, it's a virus. Well, kid comes back in 3 days later. Oh, we don't know what's going on, but let's give you some antibiotics. Let's try that. I don't know what else to do here, is what the doctors basically do. And then by the end of the week, now they're into my emergency room with a sore throat, with the antibiotics didn't help, and they're continuing with fatigue and fever and rash and swollen glands, right? So what do? Well, we've got to determine now, is it a virus? Is it a bacteria? What's going on? So we're going to do a CBC. CBC, the white count is going to show us, is it elevated? That's going to be a bacteria. If it's not, it's a virus. And a mono test, the mono will come back a virus. It is a virus. So another thing we'll do because of the sore throat and the symptoms, we'll do a mono spot test. When we do the monospot test, and I had a little boy who was 9 years old, symptoms exactly what I just said, presented just like that, had gone to the doctors twice, got to me. I was the third visit. We did the blood, monospot test, positive. What does that mean? Well, it's going to be a while for the virus to go away. But this is the problem. This is our concern. It's the swollen glands, which can be the liver or the spleen, and it can blow up like a big balloon. And if you touch it hard enough, it's going to burst. So if a spleen bursts, your child's going to die. So my little 9-year-old boy that I had came in on a Saturday morning with his father, come in exactly like that, monopositive. I taught him, the doctor taught him. I had written instructions telling him to be careful of that belly. Treat them symptomatically, but the other part is no contact sports. You must protect that abdomen from injury because a little jar could pop that liver or spleen. Well, this little 9-year-old boy, 1 week later, 1 week, and they tell you at least 3 weeks wait and get a release from your pediatrician before you can go back to PE, right? So 1 week later, we get a call, and I'm the primary trauma nurse on duty. And this little boy decided to go out on that little thing up there, that little ATV with his brother. He fell off, fell on his abdomen, and he arrived to my ER dead on arrival. Most upsetting thing that I can remember. It was a child who was perfectly fine, who didn't listen well enough. So if I can tell you all anything, and if you could teach one child not to do anything silly like that, then me telling you this story is all worth it. So again, it's a virus. Treatment, protect that tummy. And then it's symptomatic. Rest, fluids, antipyretics. Okay, probably your most concerned, congenital heart defects. Congenital heart defects is where a baby is born and the hose in the heart where the blood goes, there's a kink, there's a missing spot, there's something that's not right, which means oxygen isn't going the way it should somewhere, many times. So, what do you see? Elevated heart rate, elevated breathing, so tachypnea, tachycardia, the heart's not beating and pumping blood around well. So you're going to have swelling, whether it's legs, abdomen, eyes, doesn't matter. These children are going to tire easily. So even feeding these kids is going to be horrible. They have no energy. Exercise intolerance, just eating is too much exercise. You're going to see diaphoresis. A congenital heart child, we weigh them every day. And the reason is because little weight gain is telling us the heart is not pumping right. And now my lungs are filling up with fluid. And now I know we're even in more trouble, right? So weight is monitored very closely here. So feeding these children, how are we going to feed them? They still need nutrition, right? So small, frequent feeding whenever they want. This is not every 2 to 3 hours. If they're crying, they want food, give them a little bit. Also, usually formulas are 20 calories per ounce. Breast milk, we can also increase calories by a breast fortifier. So we can increase those calories there too. And also, never feed a child more than 30 minutes. They're just tuckered out. They're tired. They're burning the calories that you just gave them, so just don't do it. Also, there's murmurs, and we're going to go into where those murmurs are. So, this is a picture right out of your book, and it talks about acyanotic, cyanotic heart defects. There's a couple things you need to know about this. On the acyanotic, increased pulmonary blood flow. If there's a hole between the connecting between the right and left side, the septum, there's a hole on the upper or lower side. Blood comes out of the lungs and will go back over to the right side. Because if you think about it, blood goes all the way around the heart out of the left ventricle. It pumps it and it goes and it just gets back to the right side. So the right side has a little bit of flow, right? And where does shunt go from? Higher to lower. So the left side has it's actually four pulmonary veins feeding that left atrium. So the pressure is really high. So increased pulmonary blood flow, it's going to go from the lungs into the left atrium or left ventricle and back to the right side and back into the lungs. And that's why it's increased pulmonary blood flow. The other one that's increased is what we call a PDA, a patent ductus arteriosus. This is what I call an oxygen giver. Remember it in that terms. It connects the lungs, the pulmonary artery, to the aorta. So we got a direct connection from the lungs to the body. So oxygen giver, remember that. Coarctation of the aorta is not cyanotic, but it's an obstruction. It is a kink in the hose and the aorta that comes off the heart. So the left ventricle pumps, it goes up around the arch, and then there's a kink, a narrowing. Blood can't go down. So what would you see? Decreased pulses in the lower extremities, decreased blood pressure in the lower extremities. Blood can't get there, but it's got to go somewhere. So it goes back into the left side of the heart and up into the lungs. Okay. You're going to have 3, 4 plus pulses in the upper extremities. There's extra blood going there. And also, your blood pressure's higher in the upper extremities because it's got more blood going there because the blood can't go down. Important concept there. So cyanotic heart diseases. Now, tetralogy of Fallot is the one they love to pick on. Whether it's the NCLEX, whether it's Hesse, they love picking on tetralogy of Fallot. What is it? Well, tetralogy of Fallot is when the pulmonary artery kinks or tissue covers the end and blood can't go into the lungs. And they have what we call a TET spell or a blue spell. It happened to me one night. It was like 4 or 5 o'clock in the morning. I was changing. His name was Nolan Ryan. He was a 1 month old little infant with a tetralogy. And I was changing his diaper, like wiping his little face and making him really pretty. And he had a TET spell. He went from O2 sats of 100 to 10. O2 sats of 10. I mean, in a minute, less than 30 seconds, it was quick. So what do you do for a TET spell? It's what we call put the knees to the chest. And what that does, it takes the abdominal pressure and chest pressure and moves it and hopefully pops open what's ever occluding the pulmonary artery, and blood can flow back to the lungs. And that's what happened, because that's what I did to Nolan Ryan. And then he turned pink again. Scary. Now, older children, now some of them aren't fixed for whatever reason. Older children can feel this happening and automatically they squat. They just go back on their knees and squat to the floor. And it's just like knee chest, isn't it? And then the last one, cyanotic, I'll discuss is transposition of the great arteries. So think about the pulmonary artery and the aorta, opposite. So the aorta is now coming with unoxygenated blood to the body. So unoxygenated blood keeps continuing to the body. And the lungs keep going around in circle because it's just there. So how can I give this body oxygen? Oops, I got an oxygen giver, a patent ductus arteriosus. So I need now to keep it open, right? So we're going to be given medicines. I'll go to that in a second. So tetralogy. The thing about tetralogy is TET means 4 heart defects. That's why it's called tetralogy. It has to do with the word. There is a hole between the ventricles. There is that pulmonary valve, somehow stenosis or covered or whatever. The aorta sort of pulls over. And because occasionally when that pulmonary artery shuts down, blood still's coming in, so the right ventricle stretches a little bit. So that's why there's that hypertrophy, which means stretching. Okay, that's those 4 things. Most kids on tetralogy are placed on digoxin. It helps lower and strengthen that force of contraction and decreases those TET spells. So you've got a kid who is having a TET spell. They're becoming hypoxic, turning blue. Number 1, calm the child down. Like little Nolan Ryan, he got a pacifier. He wasn't intubated or anything. Gave him a pacifier. I mean, how do you calm down an infant? That's number 1, right? And we gave some morphine. Morphine is a pain reliever, but it also relaxed him. And that also helped. He was already on the digoxin. And of course, I did that knee. That is tetralogy. Most tested of all of them. You need to review that before your NCLEX. So that patent ductus, I just told you about that transposition. And I have absolutely no oxygen going anywhere in the body. Now, at birth, mommy has that patent ductus arteriosus open. It's fetal circulation. Mommy produces a hormone called prostaglandins. So when the baby's inside, mommy's feeding it this prostaglandins, this hormone. When the baby's born, oops, supply's cut off. Now that duct is going to close. And on a transposition of great arteries, we need an oxygen giver. So we are going to give a synthetic prostaglandins, a slow, continuous infusion. What does the prostaglandins do? It increases oxygen saturations and it helps that pump to beat better, doesn't it? And it prevents any central nervous system things because oxygen is going to the brain, which is what you want. Now, PDAs, when they're open, what would you hear if you listened to it just? It sounds like a washing machine. It's not a, it's a big, you can fit, sound like a washer machine, very loud. The other thing it does is look at this blood pressure, 60 over 18. Newborns are 60 over 40. That's your like 120 over 80 as an adult. So that number is low. So now you have a PDA, it's open. I hear the murmur. My blood pressure is 60 over 18, and I don't need the PDA. It's there, it never closed. I don't know. We need to get rid of it. Well, we can give something called indomethacin or Indocin. It's actually an NSAID, and it's given IV. And usually it's 3 doses we give. As we give it, you're going to hear the murmur go away, and you're going to watch that blood pressure 18 go to 40. Remember these 2 words. Atresia means there's no opening. The biggest one I like to use that for is tricuspid atresia, which means there's no opening to the right ventricle from the right atrium. That one needs an oxygen giver too. Stenosis is a narrowing. It's like that coarctation. It's stenotic, it's stenosed. There is a narrowing. Blood doesn't flow as well as it should. Okay, removing chest tubes after surgery. Again, this is telling these children it's going to hurt. I used to work in adult open hearts also. I worked the night shift. Every morning at 6 a.m., the residents came around and they pulled chest tubes. So I've got the experience of not only children, I've got the adults also, but the adults' opinion. They tell me it burns bad. So make sure that we medicate them well, all right? Be honest. Give them something for pain, take their vital signs, giving them something, sitting them up, and document the vital signs afterwards because you gave a good pain medicine. You don't want it to be too good and stop breathing, right? Transplants are done. We do these sometimes on these children who have these really bad congenital heart defects. One of them is hypoplastic left heart, and most of the transplants are usually that condition. You don't need to know that name. You just need to know that post-transplant, biggest concern is rejection. Most children die because of rejection. Digoxin, we know how to give it. We know digoxin, you're going to know what is a normal heart rate for the child's age you're dealing with. If it's an infant, if it's below 90, that's too low. Also, how do you determine if an infant is dig toxic? I mean, an adult, it could be the heart rate, they could be yellow spots, vomiting, right? Well, infants can't tell you that. Probably the one thing that you'll see is vomiting. If you have an infant on digoxin and vomiting, you're going to hold the dig, tell the doctor you're probably going to do a dig level on that child, okay? Post-cardiac catheterization, biggest concern is bleeding. So child comes back from the procedure. First thing I do is I check the right groin because they put a right femoral artery and right femoral vein catheter, and they're big. So when they pull them out, apply pressure, wait for it to stop, to clot, they put a pressure dressing on. Once it gets back to you with all the moving and rolling the child down the hall, et cetera, it could have dislodged the clot. It could be bleeding. So if it's bleeding, what do you do? That picture shows you right above the area, 2 fingers, push it down tight and hold it. And of course, call for help, all right? You need to check the extremities. Are they cold? What's the pulses on them? And keep that right leg straight. Bed rest 24 hours on these children, okay? And they'll either get IV or oral, doesn't matter, it's whatever the child should take. And any post procedure, we do check glucose. It can show what fluids they had, or sometimes it's telling you other things like sepsis and other things. So dextrose, we do monitor on that. Now, rheumatic fever is another sore throat that went haywire, right? It is something that happens where you had a strep throat, it was not treated or inadequately treated, and these are your symptoms. Fever, joint pain, rash, subcutaneous joint nodules. And the one thing we're concerned about is the damage to the heart. That valve could be damaged, and then it will be medical or surgical treatment. How do you treat a strep throat that went bad, basically? You treat the strep, long-term antibiotics, everything, including that chorea, which is irregular movements that you can't control the way you move. Everything will get better, except if it's heart damage has been done, it's done. Okay, hematological, ITP, P for platelets. It's a problem when you don't have enough platelets. And we call this less than 20,000. How do we treat it? These are children that come in with aggressive epistaxis, more than one, or they have this purpura sort of rash that is occurring and they don't go out, they don't play. You know, these ecchymotic areas, I don't know where they came from. So we bring them in and we find out, do a CBC, we find their platelets are less than 20,000. How do we treat them? Well, again, it's supportive, but we can give IVIG, help boost that immune system. It's usually after an upper respiratory, we see these things happen. Or we might give them some anti-D. When they're in a hospital, because they'll be brought in to be treated initially, we don't want to do anything to cause bleeding. They're on bleeding precautions. So avoid any stick, any venipuncture. You're going to look at that child for bleeding, whether it's purpura or bruising, ecchymotic areas, or nasal or gums, urine, anything. Watch for bleeding. And every morning they usually will do a CBC and looking, is the platelet count getting better? And this says sometimes corticosteroids. Yes, they give corticosteroids. Don't say sometimes. Types of anemia. Iron deficient anemia. Most common, we see this with toddlers, right? Toddlers don't like to eat what they should eat. So again, eggs, whole grain, raisins, these are great things. And these children, if they don't nutritionally get what they need, we might have to give them oral iron, or you might have to give them Z-Track, deep IM, iron dextran. The thing with giving oral iron, it requires acid to break it down for the body to use. So empty stomach, no milk before you eat, and orange juice with it really helps. And the other thing is, please tell your parents that that stool is going to turn black. And it can be scary if you don't tell them. Megaplastic anemia or lack of vitamin B12. This is something that you would see a tongue. It looks like beefy red. That's a symptom of it. And how do we correct it? We give B12 injections. And then hemolytic anemia, there's some conditions with that. Now, sickle cell anemia, Cooley's anemia, aplastic anemia. So sickle cell anemia is an inherited. Again, you have two parents with a trait, 25% will have the disease. So sickle cell is when the cells get stuck in bifurcations and you can't get the blood go down. So it backs up and it swells, creates pain, and it really hurts. Okay. So how and what are we going to do? What's our priority for this child? Well, We can treat the symptom or we can treat the cause. The symptom is swelling because the blood vessel is narrow and blood can't get down there. Priority, priority for sickle cell, fluids. Dilate that child, get those fluids open, put heat on them because that helps open it up. They say to put oxygen on, it works sometimes, yes, sometimes no. These children need to be told that they must keep well hydrated. We want those blood vessels plump so the blood cells keep going through well. These children do need high protein and calories. If you're going in a plane, you're going up and getting a pressurized cabin, it's pushing on those blood vessels, aren't they? This child should drink extra fluids. They should exercise. If they're in the cold, they need to put warm clothes on. They need to take their pain medicines before it's too bad, and they need to rest. HIV in children. This usually comes from mommy, unless you're an adolescent with risky behaviors. HIV in children, our biggest thing is to try to improve their immune system. We want to give them those antipyretics. We want their immune system to get the best that they can get, give them good nutrition, and prevent those opportunist infections. Now, one of the opportunist infections most common is your PCP pneumonia, pneumocystic cardiac pneumonia, that usually happens right around 3 to 6 months. The other thing that can happen, and we don't call it as much and severe, it's that candida, which is, that your tongue, and giving them their nystatin and put it on there. So infants, how would you take nystatin and put it on that tongue, which is full of all of that yeast there, right? Just take and swab it on with a cotton swab, and you put it on exactly where it goes. Now, osteosarcoma is a cancer of the bones. Most of the time, we talk about osteosarcoma, it is cancer of the femur bone. A lot of times, these are adolescents. Our goal in adolescence for this osteosarcoma is to get rid of the cancer and to salvage a limb. And what does that mean? Well, you have to take the whole femur bone out. So what's left is only the lower leg. And if we take the whole leg and the femur bone, what am I going to connect a prosthesis to? I don't have anything. So they take the lower leg, put it up, turn it around, and that's now an area where I put the prosthesis. So osteosarcoma, salvage the limb. Leukemia, what is that? It's cancer of the blood. It takes care of cancer, involves the white blood cells, but it also affects red blood cells and platelets. So not only are they decreased with infection and fighting it because of no white blood cells, they also have red blood cell problems because through the treatment, those get eat up and the cancer will eat them too. So you're going to need blood transfusions for this child here. Also, platelets. You got to worry about platelets and bleeding also with these children. As I said, Down's children are high risk for that. Poor kids. They don't really get a break, do they? So, what do we do? Well, we're going to put in some sort of port, some central line, and we're going to be given chemotherapy. And again, our goal is to give chemotherapy after that central line's in, after we determine that, yeah, this is leukemia, we're going to do 4 to 6 weeks of intense chemotherapy. And our goal is actually remission. Now, they continue doing treatment because some of the cells hide. And they want to make sure there's none in the central nervous system, there's no cells somewhere else. So they do continue and then put them on the prophylactic for a while afterwards. Antiemetics, we should give them before we give the treatment because many a times it does cause nausea. Some of the treatment for leukemia could be a bone marrow treatment. If the chemotherapy is not working, you know, we need to do something. So bone marrow. Now there's two types of bone marrow that we talk about. Autologous, automatically me, mine, mine's the best. Automatically me, mine's the best. Everybody else is all the others, allogenic. And that's how I remember it. You don't need the blood type. You don't need any of that. Siblings are the best after your own blood type. But autologous is mine, automatically mine is the best, I want it. And then allogenic is all the others. And it doesn't have to be a relative, it doesn't have to match, none of that. But as I said, siblings, same parents, is the best after your own. During therapy with cancer, and even at other times, children tend to have low neutrophil counts. Now, neutrophil count should be somewhere around 2,000, 1,500, 2,000, something like that. What happens in this treatment, you knock out the whole immune system. So neutrophils do go below 500. Now, this is when you have to be really careful with hand washing and preventing infection on these children. Another thing I want to mention about neutrophils being low, doesn't matter if the kid had cancer or not. What if the kid had a disease and is in the hospital and now has an infection, has a fever, and their neutrophil counts are low? This is a child who's about to go into septic shock. This will always be your priority patient. If you're given a group of patients, the one with the low neutrophil count and the fever is the one you're worried about. Now, Hodgkin's lymphoma, non-Hodgkin's lymphoma, you always mix them up, which one's which. Let me tell you how to remember the difference. They're both a cancer, and they're both cancer of the lymph nodes. Hodgkin's is a lodge, it's a house. You can feel it, you can touch it. It is above the shoulders. It is any big lump, like that picture. That is a Hodgkin's lymphoma. Okay, it gets bigger, it pushes against the airway, and it's Hodgkin's lymphoma. They do a biopsy, radiation, chemo, and then they can take it out. Non-Hodgkin's lymphoma is diffuse. It's tiny little pieces everywhere. It's really hard to find. So the difference, Hodgkin's, I can see it. It's above the shoulders, okay? Non-Hodgkin's, it's going to be hard to find it. Brain tumors in children, of all the type of solid tumors, it is the most common. What symptoms would you see with these children? Well, these children all of a sudden are getting headaches that are getting worse. So symptoms are getting worse, okay? Vomiting, that's not related to feeding. These are those two symptoms that you look at going, something is going on here. Then we determine it's a brain tumor. They're going to put those marks, those purple marks on for radiation. The one thing about those marks you need to know is you can't wash them off until all of the radiation therapy is done. Wilms tumor is a kidney tumor. It's also called a nephroblastoma. Remember, some of these children have a problem with blood pressure. So again, things that you need to watch for. The thing about Wilms tumor is even before surgery, they won't even do a biopsy. You can't manipulate this tumor because it's fragile and it will break off and metastasize in the body. So this child, there's going to be no biopsy. We'll do chemoradiation and then we'll surgically remove it. CPR for children, you always need to review your CPR. You're going to have a question on it, guaranteed, in every exam. Know what's 1 man, what's 2 man, what is going to be 15 to 2. We're going to be breathing when you call for help. So do a review on it. Here is the algorithm that you have. And you do have all your cahoots here, and you know that there will be some dosage calculation. If you need help with it, dosage calc, let me know. I'm here to help you with it. I'm actually pretty good at it, so they say. Any questions from anybody?
No, ma'am. Thank you very